The next clinical entity is potentially difficult to differentiate from schizophrenia. Delusional disorder refers to a patient with a fixed, persistent, non-bizarre belief system that lasts for greater than a month. However, their day-to-day functioning tends to be intact. Imagine a married businessman who is successful at work who holds the delusion that his only child wants to kill him. He may carry this delusion and make adjustments in his life to avoid his child, but otherwise carries this delusion without any serious consequences on his day-to-day functioning. A high-yield way to identify this entity in Step 1 questions is that vignettes usually identify a patient with only a single belief or fixation, as opposed to patients with delirium or true schizophrenia that may be described as having multiple bizarre beliefs. Remember, though, that delusions are one of the diagnostic criteria of schizophrenia, so if a person has delusions, and also any of the other 4 criteria for a period of 6 months, they would have schizophrenia. A distinct clinical entity is shared psychotic disorder, wherein a person closely associated with an individual with delusional disorder also develops the same delusions, thus the folie à deux, or madness of two. See, all those years of high school French are paying off. For example, if the wife of the businessman in the prior example also begins to believe that her child wants to kill her husband. Shared psychotic disorders often resolve when you separate the two individuals. Remember when we discussed dissociation as an immature defense mechanism? In short, it refers to a temporary drastic disruption in the personality, memory, or consciousness of an individual to avoid stress. Extreme forms of this defense mechanism manifest as the following disorders. For example, in dissociative identity disorder, individuals may develop multiple distinct identities. These classically occur in patients with a history of sexual abuse. A similar disorder is a dissociative fugue. Classically, these happen when you have natural disasters or wars, where individuals lose the ability to remember details about themselves. A good example would be a Hurricane Katrina victim who fails to remember details about their childhood and individuals from their upbringing. The word fugue in psychiatry refers to a period of memory loss, which is in turn not remembered when a patient's original memory is returned, not to be confused with the type of musical piece. Let's say this Hurricane Katrina victim was able to recover from the episode, but as a result could not remember any details from the hurricane itself. What psychiatric phenomenon would they be exhibiting? That's right, dissociative amnesia. A final dissociative disorder is depersonalization. This refers to a persistent feeling of detachment or estrangement from one's own body. Patients often complain about feeling like they're going through the motions of their day-to-day activities. Art historians hypothesize that Edward Munch's The Scream was inspired by this disorder. A good high-yield way to identify this disorder in vignettes is to look for an individual who experiences extreme stress but seems apathetic or unaffected by it, such as a person who just lost their job, house, and significant other, but doesn't seem to care at all. Of course, we're assuming here the person valued these things or people previously. So this brings us to mood disorder, about which there are 2 major facts you need to remember, namely that it involves an abnormal range of moods or internal emotional states that are often very severe and intense. Also, that patients lack control over these emotions. These disorders cause occupational and social disturbances, as well as a high degree of anxiety. It encompasses bipolar disorder, major depressive disorder, dysthymic disorder, and cyclothymic disorder. It's also important to realize that the psychotic features of hallucinations and delusions may also be present. In the setting of clinical vignettes, focus on looking for clues that suggest the patient's emotions are at the core of their daily life disturbances, as opposed to psychosis. 2 common mood disorders, bipolar disorder and major depression, are very high yield for the boards. Before we go into bipolar disorder, we must first define what a manic episode is. Again, we'll begin with the distinct clinical criteria that are used to define a manic episode. You can remember them with a mnemonic, dig fast. That is to say, distractibility, irresponsibility, grandiosity, flight of ideas, which refers to racing thoughts, increase in goal-directed activity, that is to say, obsession with accomplishing a task, decreased need for sleep, and talkativeness. Of these 7 criteria, you need 3 in order to fit the diagnosis. A distinguishing characteristic of a manic episode is that they often are disturbing to the patient and lead to impairment in social and occupational functioning. A milder form of a manic episode is a hypomanic episode, where an individual experiences similar symptoms, but that are not severe enough to cause marked impairment in functioning. These symptoms must also last for at least a week to qualify as a hypomanic episode. Be on the lookout for an individual that experiences some of the same 7 criteria previously outlined for a manic episode, but that otherwise leads a normal life. Also be careful to mind the minimum 1-week time span. A lot of med students probably experience a couple of these symptoms for a few days around exam time. So while it's important to know the definition of a hypomanic and a manic episode, they are not technically the illness themselves. Any individual who has a single manic or a single hypomanic episode is defined as having bipolar disorder. This is often difficult for people to understand because the term bipolar, or 2 poles, suggests that there should be some depressive symptoms along with the manic symptoms. While this is true, patients are given the diagnosis of bipolar disorder following a single manic or hypomanic episode because these patients will invariably develop depressive symptoms at some point. Between these episodes, patients often stabilize their mood naturally. Patients are often treated with mood stabilizers, classically lithium, valproate, and carbamazepine, or atypical antipsychotics. You should not treat these patients with antidepressants. This is because antidepressants can increase the severity and frequency of manic episodes. A milder form of bipolar disorder is cyclothymic disorder, where patients alternate between hypomanic symptoms and mildly depressed or dysthymic symptoms over a period of at least 2 years. A milder form of bipolar disorder is cyclothymic disorder, where patients alternate between hypomanic symptoms and mildly depressed or dysthymic symptoms over a period of at least 2 years. Again, we see the value of memorizing time span criteria in psychiatry. As we did for bipolar disorder, we'll first define a major depressive episode and then discuss major depressive disorder. There are 9 clinical criteria that help make the diagnosis of a major depressive disorder, of which you need at least 5, which must last for a minimum of 2 weeks. These can be remembered with the mnemonic SIG-E caps: sleep disturbance, loss of interest, guilt, energy loss, concentration loss, appetite change, psychomotor changes, suicidal ideation, and while it's not included in the mnemonic, a depressed mood. This is actually the only one of the 9 that the patient must have. You'll hear this acronym thrown around in the hospital as well, so it's worth committing to memory for more than just test purposes. Major depressive disorder, recurrent subtype, requires 2 or more major depressive episodes with a symptom-free interval of at least 2 months. A related disorder is referred to as dysthymia, where patients suffer from a milder form of depression, which symptoms do not meet the criteria of major depression, but last for at least 2 years. You may also encounter questions about seasonal affective disorder, which is a form of depression linked to decreasing sun exposure during the winter months. The key to identifying this disease is the resolution of depressive symptoms with increased full-spectrum light exposure. We just discussed major depressive disorder, recurrent, which is one subtype of major depressive disorder. Another subtype, incidentally the most common type, is atypical depression. This is often characterized by hypersomnia, which is sleeping more than usual, overeating, and mood reactivity, meaning the ability to experience improved mood in response to positive events. Oftentimes, these patients will gain weight and be very sensitive to rejection. Atypical depression is common in younger patients, such as teenagers, and is usually treated with MAOIs or SSRIs. Postpartum patients are subject to many possible mood disturbances, most of which are benign, but some of which may not be, and will require intervention. The first one is called postpartum blues, and it occurs in 50 to 85% of women. It often manifests with depressed affect and fatigue, but will resolve within 10 days without any form of treatment. It's important to follow these women for the development of postpartum depression. Postpartum depression occurs in 10 to 15% of patients, which is also characterized by depressed affect, and it may last from 2 weeks to 2 months. These will often necessitate treatment, including psychotherapy and antidepressants. Again, the key here is to commit to memory the differences in time scale. I really like alphabetical mnemonics, so I remember that blues comes before depression, just like B comes before D. Postpartum psychosis is a more serious clinical entity, though uncommon, and it's characterized by delusions and may even cause homicidal or suicidal ideations or attempts. It usually lasts about 4 to 6 weeks. Often it will require pharmacological intervention and, if necessary, inpatient hospitalization. There are many seemingly barbaric treatments for patients with depression, of which many will not appear on your boards. One with important historical significance, however, is ECT, or electroconvulsive therapy. Here, patients with refractory recurrent depression will be treated with what should be thought of as a painless seizure. Patients may experience disorientation and/or amnesia, but this is usually temporary. While not the most common treatment, it's still used and has impressive success rates for patients who have failed medical therapy, and it's generally considered safe, even in pregnancy, a fact that may be worth remembering for test questions. While not particularly boards relevant, risk factors for suicide completion is a very standard wards topic. There are certain red flags for suicide completions that should be fully evaluated in patients who exhibit signs of suicidal ideation. People with the highest risk are males, teens, the elderly, patients with major depressive disorder or previous suicide attempts, alcoholics, those who lack rational thinking or are sick, and those who are single or lack social support. Appropriately, the mnemonic for these risk factors spell out sad persons. It's worth noting that women are more likely to try suicide, but it's the guys that actually succeed more often.